Hello, thanks for your interest in the health of refugees who are resettled in Utah, specifically those who are age 60 and older. A little bit of background on refugees. There are about 80 million people in 2019 who are considered displaced from their usual residence. That is the high point on this graph. About a fourth of those are received the designation of refugee and are subject to the guidance or protection of UNHCR in terms of being resettled. And those are the people we're concerned with in this particular investigation, are those who are resettled to the United States. This graph shows you that the number of refugees resettled in the US has fluctuated over time. We are at the low point in 2020 in terms of the numbers who were resettled. The Biden administration has recently increased that cap, and we think we'll be in the neighborhood of 62,000 over the next several years. We likely won't meet that this year. But our data are in this area of the gray rectangle, which puts us in the neighborhood of 60 to 70,000. And so this time period of 2012 to 2017 for our study is relevant to where we're headed with this new cap. The data are a secondary data analysis from the Refugee Health Screening Form and were provided to us by the Utah Department of Health. We did the analysis on refugees who were age 60 or older, and during our study period, there were 217 of them. Our main findings are that the prevalence of having a condition that is referable or notable on the screening form is high. For our study, 91% of people had a referable condition. This graph shows you, based on the prevalence, starting on the left side of the graph, higher prevalence, and working our way to the right with lower prevalence. The x-axis represents the areas where the referral would be made. And so I'll talk about those in just a minute. Blue bars designate findings for men. Red are findings for women. Ophthalmology was our highest condition, not surprising in a group who's age 60 and older. But basically, this really refers to decreased vision, and for the most part can be corrected with a prescription. The next group, cardiology, was predominantly hypertension and came in a little over 40%. Infectious disease represented, for the most part, latent tuberculosis and would not require any care at this particular time. You'll see next a group that has several labeled with psychology and one musculoskeletal. Let me first talk about musculoskeletal. This referred to arthritis and low back pain. The three psychology groups have to do with the different areas of the form. Psychology was a diagnosis, and psychology with RHS1 or 2 was from a screening exam. So RHS1 is screening for conditions such as anxiety, depression, and PTSD, and that was the predominant diagnosis in the category of psychology as well. So those two can be thought of together. The RHS2 is a screening for stress. And so you'll see the range on the psychology findings goes from a little over 20% to about 40%. Gastroenterology was the next category on this figure, and that represented predominantly abdominal pain. And you can see that the conditions are becoming less prevalent as we go along. The second major finding is that there are some differences between men and women. Women had higher prevalence for both the musculoskeletal and gastroenterology categories, while men had higher prevalence for pulmonology, which reflected their use of tobacco relative to women. Lastly, we'd like to talk about how these findings might guide the work going forward as refugees are being resettled again in Utah. First is that there's a very high prevalence for individuals of having some finding on this intake exam when they arrive in Utah, and that treatment, which is linked to better health outcomes and lower mortality, will require that we address both structural and cultural barriers. The second thing I want to talk about is the difference in terms of the relationship with a refugee and a clinician in terms of simple versus complex care examples. Vision, as I mentioned, is a relatively simple fix. So, low vision can oftentimes be corrected with prescription lenses and would be probably a one time visit. Hypertension, as an example of a complex care, will likely require multiple visits and oftentimes the addition of addressing comorbidities that go along with hypertension. I do want to mention that there's an integration impact to all of this. So, when we think about someone coming into a new community, we want them to relatively quickly feel comfortable in that community and successful. And even the simple fixes can sometimes get complicated in terms of this integration impact. Let me go back to the example of vision. If someone has structural or cultural barriers and does not seek care and get corrective lenses, then it may become harder for them to, in school, acquire new language skills as they are trying to integrate into a country that uses a different language than their first language. This may also impact their ability to successfully compete for a job or to move forward in a job. And so even the simple examples become a little more complicated with this idea of integration. Here are the acknowledgments for the work that we did and my contact information. And I wanted to thank you for spending time with us at this poster.